Cephalosporins are beta-lactam antibiotics, defined by their 4-member core beta-lactam ring. There are 5 distinct generations of cephalosporins, each with unique clinical considerations. In general, the earlier generations of cephalosporins have superior gram-positive activity, and the later generations have more gram-negative activity. The first generation includes Cefazolin and its oral equivalent Ceftriaxone. They have excellent coverage against Streptococcus species and methicillin-susceptible Staphylococcus aureus. Gram-negative coverage is narrow, but includes reliable coverage for Proteus mirabilis, E. coli, and Klebsiella pneumoniae. Cefazolin is often used for surgical prophylaxis and for methicillin-susceptible Staphylococcus aureus and streptococcal infections, but first-generation cephalosporins are not first-line for any neonatal infection. Cefazolin can be used for directed therapy against methicillin-susceptible Staphylococcus aureus bacteremia in neonates if meningitis is ruled out, but we usually prefer nafcillin for MSSA bacteremia or meningitis. The second generation includes oral cefuroxime and the IV cefamycins, cefoxitin and cefotetan. Cefuroxime covers Streptococcus species and only moderately covers methicillin-susceptible Staphylococcus aureus. Gram-negative coverage is expanded versus Cefazolin, adding Haemophilus influenzae and Neisseria meningitidis coverage. Cefoxitin and cefotetan are unique in that they only cover anaerobes. We do not use any of the second-generation cephalosporins in neonates. The third generation is the first that is extended spectrum and includes Ceftriaxone, Cefotaxime, and Ceftazidime. Ceftriaxone and Cefotaxime have almost identical spectrums of activity, including enhanced activity against some beta-lactamase-producing strains of Haemophilus influenzae, E. coli, and Klebsiella pneumoniae. Ceftazidime has similar pharmacokinetics to cefotaxime, but its spectrum of activity is very different. Unlike Ceftriaxone and Cefotaxime, Ceftazidime has no gram-positive activity. Instead, it has an extended spectrum of gram-negative activity, adding Pseudomonas coverage. While initial susceptibility to more resistant gram-negative organisms like Citrobacter, Enterobacter, and Serratia species is likely, the third-generation cephalosporins can quickly induce resistance to these organisms by encouraging the expression of AMP-C, a high-level cephalosporinase, which, when upregulated, will hydrolyze the extended side chains of these cephalosporins, rendering them ineffective. So, susceptibility results do not guarantee clinical effectiveness to these organisms. In neonates, the major gram-negative organism that we want to empirically cover is E. coli. Some strains will be resistant to third-generation cephalosporins through the production of extended-spectrum beta-lactamases, but the majority of E. coli strains in neonates do not produce these beta-lactamases and are reliably susceptible. Cefotaxime was the standard third-generation cephalosporin used for neonatal sepsis and meningitis in the US until its shortage in 2015. It has been used as monotherapy, combined with ampicillin, and combined with gentamicin with or without ampicillin dating back to the 1990s when E. coli resistance to ampicillin first became a concern. Today, empiric cephalosporin use is not recommended in place of gentamicin unless meningitis is suspected, or the neonate has acute kidney injury or gentamicin-induced nephrotoxicity due to associated morbidities and mortality. Also remember that Listeria and Enterococci are inherently cephalosporin resistant, so if indicated, cephalosporins should be combined with ampicillin empirically for early onset sepsis management. Of note, only cefotaxime has good CNS penetration among the third-generation cephalosporins in neonates. See my video on ceftriaxone's contraindication in neonates for more guidance on cephalosporin use. Another important caveat with third-generation cephalosporins is that the oral options Cefdinir, Cefotaxime, and Cefotaxime are not equivalent to the IV agents, as they have significantly lower oral bioavailability, limiting their in vivo spectrum of activity. Cefepime is our 4th-generation cephalosporin. Its gram-positive coverage is slightly superior to the 3rd-generation cephalosporins, but the major difference is its improved stability against hydrolysis by AMP-C beta-lactamase-producing gram-negative organisms. Compared to ceftazidime, resistance is less likely to be inducible with Cefepime. So, Cefepime has more reliable long-term efficacy against organisms like Citrobacter, Enterobacter, Serratia, Morganella, and Providencia species. Neonatal studies also show less development of pseudomonal resistance to Cefepime versus ceftazidime. With Streptococcus and MSSA coverage, Cefipime's spectrum of activity is more comparable to Cefotaxime's. Remember that ceftazidime only has gram-negative coverage. After cefotaxime, Cefepime has the best CNS penetration among the extended spectrum cephalosporins. For all of these reasons, when needed, I prefer Cefepime over ceftazidime in place of cefotaxime in neonatal sepsis and meningitis management. The newest cephalosporin is 5th-generation Ceftaroline. It has the best gram-positive coverage of all the cephalosporins, and is the only one that covers Enterococcus species and methicillin-resistant Staphylococcus aureus. It has similar gram-negative coverage to Ceftriaxone and Cefotaxime. While still new, Ceftaroline is FDA approved in neonates at least 34 weeks gestation and 12 days old for acute bacterial skin and skin structure infections, and in children over 2 months of age for bacterial pneumonia. A phase 2 study published in 2020 suggests that Ceftaroline may be safe and effective for neonatal late-onset sepsis, but this study included only 11 infants. All were at least 34 weeks gestational age. Only 2 infants were preterm, and individual gestational ages were not reported. CSF penetration was not investigated. Like other beta-lactam antibiotics, cephalosporins inhibit bacterial cell wall synthesis by binding to and inhibiting penicillin binding proteins, which are enzymes involved in the final stages of peptidoglycan cross-linking, an essential process for maintaining the structural integrity of the bacterial cell wall. Adverse effects associated with cephalosporins include diarrhea, rashes, seizures, kidney or liver dysfunction, thrombocytopenia or thrombocytosis, leukopenia, eosinophilia, and anemia. It is important to note that broad-spectrum cephalosporin use increases antibiotic resistance and risk of extended-spectrum beta-lactamase-producing organisms. Particularly in extremely low birth weight infants, extended-spectrum cephalosporins also increase risk of candidiasis. Ceftriaxone can displace bilirubin from albumin binding sites, causing hyperbilirubinemia. It can also form precipitates with calcium when co-administered, leading to biliary pseudolithiasis. See my video on ceftriaxone's relative contraindication in neonates for more information on this. In neonates, cephalosporins may be used in place of gentamicin in select situations, but we generally avoid their use due to spectrum of activity limitations relevant especially for empiric early onset sepsis and associated adverse effects and outcomes. However, it is important to know the differences in spectrum of activity across the generations so that the appropriate agent can be selected if needed. Thanks for watching. Please let me know in the comments what topic you'd like me to cover next.